All right, welcome everyone. We're going to start in about 1 minute. All right, so it's the top of the hour, so I think we'll begin. So welcome everyone to the Leukemia and Lymphoma Society of Canada's webcast, MDS, Transformation to AML. Today, Dr. Kevin Brown, a hematologist at Cancer Care Manitoba, will discuss the relationship between myelodysplastic syndromes and acute myeloid leukemia, and the risk factors which may lead to this transformation. So to begin, let me introduce myself. My name is Charlotte Hall-Coates, and I'm the Community Services Lead in the Atlantic region with the Leukemia and Lymphoma Society of Canada. I will be your host for today's event. This presentation will last approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invite you to type your questions and comments into the Q&A box on your Zoom panel throughout the presentation. An LLS staff member will monitor the questions, and I will read aloud your questions at the end of the presentation during this period. The session is being recorded, so you can always come back and watch it again on our website. Before we begin our main presentation, I would like to share with you our mission and highlight some of the resources that you may find helpful for either yourself or someone that you know. Next slide, please.
Oh.
Great. So at the Leukemia and Lymphoma Society of Canada, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer support at every step of the way. Do not hesitate to connect with a community services lead in your area to learn more about our programs and resources. Next slide, please. So last November, we launched our brand new website, bloodcancers.ca. The website was designed with you all in mind to ensure easy and personalized navigation, no matter your current situation. On our website, you will find all our past webcasts, our podcast channel, information sheets, practical tools to help you navigate your blood cancer experience, and much more. So you can find those all at visiting bloodcancers.ca. Next slide, please. Today's presentation was made possible thanks to the collaboration with the Aplastic Anemia and Myelodysplastic Association of Canada. AMAC is a nonprofit organization that provides a support network for Canadian patients, family members, and friends, and concerned healthcare providers dealing with aplastic anemia, MDS, and PNH. AMAC is a federally incorporated and registered national nonprofit charity that was founded in 1987 through a concerned parent whose child had aplastic anemia. AMAC is guided by dedicated volunteer members of the board of directors and a distinguished team of medical advisors from across Canada. You can learn more by visiting amac.ca. So it is now my pleasure, next slide please, to introduce today's speaker, Dr. Kevin Brown. Dr. Brown is a hematologist at Cancer Care Manitoba with a clinical focus on patients with acute leukemia, complex myeloid neoplasms, bone marrow failure, and those requiring cellular therapy, including bone marrow transplant. He is currently completing a master's in management through the International Masters for Health Leadership program at McGill University. His non-clinical interests include medical education, health leadership, and health economics. Thank you so much for being here with us today, Dr. Brown, and over to you.
Thank you, Charlotte, for the kind introduction, and thanks to all of you on the line for signing up for this event and listening to what I have to say. As Charlotte said, I'm a hematologist at Cancer Care Manitoba in Winnipeg, Manitoba. I mainly have a clinical focus in patients with acute leukemias and myeloid malignancies, such as myelodysplastic syndrome, and I also am trained in bone marrow and stem cell transplantation. I also have an academic appointment in the Department of Internal Medicine at the University of Manitoba, currently as an assistant professor. Before I get started, I just want to make some disclosures. I have no commercial disclosures. I have no connections, financial connections with any pharmaceutical companies. Today, I'm going to be discussing some medications, and I'm only going to be discussing medications that are approved in Canada. If you search on the internet, you may find information from other countries that talk about different drugs. Some of those drugs may not be approved in Canada. So today I'm just going to be talking about the Canadian context. And I've tried to keep my presentation to talk about standard of care in routine situations. You or your loved one may have unique characteristics that might indicate a different management plan. And in the interest of time, and keeping this presentation as simple as possible, I've tried to keep things to the most routine scenarios. Another small disclosure I'll make is that I'm getting over a cold, so if at any point I have to cough and take a sip of water, just please excuse me for a moment while I do that. I've come up with 4 objectives for today's talk. And I'm going to sort of, I've broken down the presentation into 4 sections based on these objectives. First one is to explain the relationship between MDS and acute myeloid leukemia. The next is to define the MDS risk factors that may lead to acute myeloid leukemia, outline the strategies to prevent progression of MDS to AML, and then also at the end briefly explore the specific treatments for AML that has transformed from MDS. I put this slide in, this is a uniquely personal thing for me. Just as I was preparing for this talk last month, my own father was diagnosed with low-risk myelodysplastic syndrome. So he is a non-medical person. He's just a retired government employee from Winnipeg. So he has no background in medical knowledge. So I kind of had to go through some of the things that we're going to talk about today with my dad as he sort of processed the diagnosis. So I just want you to know that I've tried my best to make this as patient level as possible, because I know that sometimes when we see our physicians, they talk at a higher level of understanding that doesn't necessarily make sense to patients. So I've tried my best using my own unique personal experience to go through this talk. So the first objective that, as I stated, is to explain the relationship between MDS and AML. I personally approach MDS and AML as a spectrum of disease, okay? I kind of, in lots of cases, see them as the same disease, but MDS being a much milder form of AML. And there's a chance that sort of the MDS could eventually progress to the more severe or more aggressive form of the disease, which is known as AML. And that's what we're going to talk about today. Both MDS and AML at their core are caused by damage to the chromosomes that live in our stem cells, that live in the bone marrow, okay? And the damage to these chromosomes are called mutations. So you may have heard your physicians talk about various mutations that you may harbor in your bone marrow. This is what they're talking about. These mutations lead to dysfunction of the stem cells in the bone marrow, which leads to ineffective production of our bone, of the cells in our bone marrow. So this manifests itself as low blood counts, mainly low hemoglobin, low platelets, and low white blood cells. Over time, more mutations can occur, which eventually stops the production of blood cells altogether and leads to an accumulation of bad cells, or you'll hear these terms blast cells, which are leukemia cells. So these mutations these additional mutations don't always occur, but they can occur. And we're going to talk about how these increased mutations can occur over time and what the risk factors are for transforming into these accumulation of bad cells, or the leukemia cells. As I said, as more mutations develop, the low white blood counts worsen, often because of dysfunction and subsequent destruction of the red blood cells, platelets, and white blood cells. As well, the accumulation of the bad cells, the blast cells, takes up the room in the bone marrow where the good blood cells are normally produced. It takes up the room of that production, and therefore causes low blood counts in that way. Blast cells can be found both in your bone marrow or in your peripheral blood. The peripheral blood is where the normal CBC that you might get on a regular basis gets tested from. Once the blast count reaches 20% of all of the cells in either the peripheral blood or the bone marrow, at that point we can make the diagnosis of acute myeloid leukemia, or AML. And on the left-hand side of our slide here, there's a nice picture from an article that was recently published that sort of outlines how we can progress from MDS to AML. So you can see in the top square here, I'm not sure if you guys can see my pointer, but if not, you can see in the top square, this is the normal bone marrow. This is what we're supposed to see in the normal bone marrow. And you see that hematopoietic stem cell, that is sort of the most immature cell, and then there's the precursors for your white blood cells, your red blood cells, and your platelets. With time, there may be mutations that lead to some of the bad cells starting to accumulate. And as you can see in the bottom here, the pink cells are the blast cells. So in the second frame, you can see we've got all of the normal cells that we would like to see, but there's a few of these pink cells here that are starting to accumulate. And maybe some of these other cells aren't necessarily being produced in the way that they should. So this is where you're at MDS, okay? Then what we think happens is another mutation occurs that gives an advantage to these blast cells, to a survival advantage over the regular cells, such that they start to grow in a more effective way than the normal cells that we're supposed to see. And this is when we start to see that at least 20% of the cells that we see in this bottom square here are blast cells. And this is when we reach the term AML. The type and number of mutations that one has dictates the risk that someone has to transform from MDS into AML. And we can detect and measure these mutations from the following test on your bone marrow biopsy. Your doctor may have talked to you, almost surely has talked to you about cytogenetic mutations. But more recently, there's something called myeloid next generation sequencing, which detects even more discrete, smaller mutations that we weren't able to detect on cytogenetics, okay? So between the two of these, we're able to risk stratify people. So next, we're going to define the risk factors that may lead to MDS transforming into AML. And if you'll excuse me, I'm just going to take a sip of water. So what defines the risk of transforming to AML from MDS? And this is the question that many of you on the line may have. And in my clinic, this is what patients want to know all of the time, so they can prepare themselves for the future and what their disease may look like, okay? And one thing I really want to emphasize to everyone on the line is there's nothing you can do to alter the risk of transformation to AML. This is unfortunate because we always would like to do something to try to make things better, but this isn't something that you can eat something healthier or exercise more to change. This is a change in, as I said, in the chromosomes and the DNA in your stem cells. And there's nothing we can do to alter that, unfortunately. Okay, so there's nothing you as a patient can do in your lifestyle to reduce that risk. Okay, but at diagnosis, there's things that we can do using your blood counts, your cytogenetics, and your myeloid next generation sequencing that help us define an individual patient's risk of transforming from AML to MDS and predict as best we can what that risk is. So I'm going to go through two of those scoring systems with you. Okay. The most common one, the most frequent one, and I would imagine all of you on the line who live in Canada may have heard about this score because it's the most commonly used score in Canada. It's called the International Prognostic Scoring System Revised, or the IPSSR. And it's probably the most widely used scoring system currently, and it predicts two things. One, the thing that it predicts is our transformation risk of transformation to AML, as well as our overall survival. Okay, and it uses from at diagnosis your bone marrow blast percentage, your hemoglobin level, your absolute neutrophil count, your platelets, and your cytogenetics. Okay. And one thing I've underlined here is this is at diagnosis of MDS. You can't be midway through your disease journey and recalculate your IPSS. It's only really validated to predict from diagnosis, okay? Because there's a whole bunch of different things that can change in the middle of someone's disease course. For instance, you could be on a treatment that decreases your hemoglobin level that may make your IPSSR score go much higher because your hemoglobin level has dropped. But in fact, it's not because of your underlying MDS, it's because of the treatment that you're on, okay? So it's only at diagnosis before you're on any treatment for your MDS that this is applicable. And I'm gonna go through how we go about calculating this because it's helpful to understand from a patient perspective what exactly we're looking at. Your physician will probably tell you what your score is and what that means based on your score, but I'm gonna show you what we actually look at, okay? So the first thing to do is to look at our cytogenetics, and this is from your bone marrow biopsy. And basically you find whatever abnormalities you might have in your bone marrow, and you give yourself the risk category, okay? And I was given some of the questions that have been submitted prior to this presentation, and many of you had questions about your cytogenetic abnormalities. So this is the risk categories for all of the cytogenetic abnormalities that we think play a major role in dictating the risk of MDS. Okay, these aren't all of the cytogenetic abnormalities that we can find. We can find many more cytogenetic abnormalities, but these are the ones from multiple years of study that we know actually affect the prognosis and outcome in MDS. So you find where you are in that category, okay? And that's the first thing that you do. Then you go down to table number 3, and you go through each of the prognostic categories that we talked about. So first, starting with the cytogenetics. So let's say you're in a very good cytogenetic category, you give yourself a 0. Then you find out what your blast percentage is, and you give yourself a score between 0 and 4. Hemoglobin, same thing. Give yourself a score between 0 and 1.5. There are no 2, 3, or 4 for hemoglobin. Same thing with platelets and absolute neutrophil count. And then what you do is you add all of those numbers together, okay? And that gives you your RIPSS score. Based on your RIPSS score, you go to this next table here and find whether you're in the very low, intermediate, high, or very high risk category, okay? And then you take that and you see where you lie in these, in the two two things this predicts, both transformation to AML and median overall survival. Unfortunately, the way this study was done, transformation to AML is reported in a very strange way. Basically what it calculates is the median time for 25% of patients in that risk category to transform to AML in years. So it's kind of weird and kind of hard to totally understand, but I think it gives you a pretty good understanding of where your risk lies. If you have low or very low risk MDS, you actually have not a very high risk of transforming to AML over time. Whereas if you're in the higher risk category, you know, many of these patients transform to AML within the first year or so after their diagnosis. Similarly, with overall survival, this is you know, in very low risk, you have a much higher overall survival than in a very high risk. One thing I just want to explain to you about overall survival: most people that were in this study were greater than age 65. So these are people who, sure, you may say 8 years sounds good, but it's also not fantastic. At the same time, you have to remember that the median overall life expectancy in Canada is somewhere around 75 to 80 years old, depending if you're a male or female. So if you're in your early 70s and you're given a diagnosis of very low risk AML, or sorry, MDS, that actually might mean that your life expectancy is actually quite similar to the overall population. Obviously, with very high risk, that becomes less true. But median overall survival has to be taken in the context of how old the patient actually is at the time they're diagnosed. So that's the IPSS-R score. And still today, that's the most commonly used one. And that's normally what I'm using with my patients in clinic. However, hot off the presses is the IPSS-M, which is it stands for IPS, or International Prognostic Scoring System Molecular. And the paper that looked at this explains to us how to do this score was just published June 12th, 2022. And it was presented at one of our major conferences earlier, or I shouldn't say earlier this year, late last year in December of 2021. So we've only really known about this for about 6 or 7 months, and it's not standard of practice yet, okay? But what this does is it incorporates myeloid NGS testing. So that's that much more specific mutational testing, in addition to the characteristics in the IPSS-R. And it's felt by the authors to provide a much more accurate prediction of risk to transformation of AML and overall survival. And I'm not going to go through how to calculate this one because it's actually quite complex. You can find it at this web address here. And you actually have to plug in all of the variables, and then it spits out a score for you. It's not as simple as the IPSS-R, but felt to be more accurate. And I think over the next the coming years, as various practice groups begin to review this data, again, it only came out less than or just over a month ago now. As more practice groups review this data, I think this will overtake the IPSS-R and being the most common score that we use to predict someone's risk of transformation to AML and overall survival. Next, I'm going to outline some strategies to prevent progression of MDS to AML. Always when deciding to treat MDS, there's two things that I keep in mind that I'm trying to do. One is trying to improve the blood counts, because that's usually what's causing the patient the most problems. So patients may have difficulty with shortness of breath or fatigue because of their low hemoglobin, or they may have some bleeding issues because their platelets are too low, or they may have issues with infection because their white blood cell count is too low. So I'm always looking at that and trying to improve the blood counts so that patients can have a quality of life that is meaningful to them. The next thing that I'm looking at is trying to improve the patient's overall survival and improve or decrease their risk of or preventing the progression to acute leukemia. Okay. Physicians will generally make decisions on when and how to treat MDS based on a patient's IPSSR score. So lower risk MDS, which in the IPSSR score is very low or low risk MDS, generally don't require treatment other than supportive care to keep their blood counts at a level that is helpful to the patient to keep their quality of life. But as we discussed, these patients probably don't need any treatment to reduce their risk of transformation to AML because the risk of that over time is actually quite low. And the idea would be is that the risk of treatment is actually much higher than the risk of the risk of the transformation to AML. Okay, that situation is different in higher risk MDS, which we generally classify as intermediate high or very high. These patients, in addition to needing help with improving their blood counts to maintain a quality of life, often require what I'm going to term as MDS-directed care or treatment to try to prevent the risk of transformation to AML. Because at that point, the risk of transformation to AML is felt to outweigh the risk of treatment. Okay, keep in mind that all of the treatments that we have risks associated with them. So as physicians, we're always trying to balance that risk and make sure we're making the lowest risk decision for the patient. There's only 2 treatments at this point that have been proven in the literature to prevent progression to AML. The first one is azacitidine, and the second is allogeneic stem cell transplantation. Okay, and I'm going to talk about each of those individually. Many of you may have heard of azacitidine at this point because it's probably the most common drug that we use for MDS in Canada. It's a chemotherapy drug that's given as a subcutaneous injection. And when I say subcutaneous injection, what I mean is it's given in an injection in a subcutaneous area, so an area of fat under the skin. It's almost identical to an insulin injection, which almost everybody is familiar with because most of us know somebody who has diabetes and takes insulin. So it's similar to an insulin injection. It's given 7 days in a row every 28 days. And then after the 28 days is over, you'll do it 7 days in a row again. Okay. And it's generally only given to patients who have higher risk MDS. And it's generally given until one, it no longer works. In other words, the MDS progresses or gets worse while on azacitidine, or it turns into AML, or it's no longer tolerated. Generally, azacitidine is very well tolerated, and very rarely do I have to take patients off of it because it's not well tolerated. The main things that patients tell me in clinic as far as side effects go is lots of fatigue with it, but generally not something that you need to quit azacitidine altogether, and constipation is a big thing with azacitidine. Sometimes we do have to stop because azacitidine can lower the blood counts on its own, and sometimes blood counts get too low while on azacitidine, which makes it difficult to keep the patient's quality of life. If I give a patient azacitidine and all of a sudden they require blood transfusions or platelet transfusions, I'm probably not doing the right thing for the patient, because that's not what my goal is to make them need transfusions. There was a big trial. It's the same trial here that you'll see on the previous slide that showed that in comparison to best supportive care, so that would just be things like transfusions and some other therapies to help with MDS, that patients who were in the azacitidine arm had a longer median time to transformation to AML. But median means, for those of us who aren't as statistically inclined, is that half of the people in the group took longer than 15 months and half took less than 15 months. And the higher the median, that means the longer the time. So it's a difference of about 5 months on average, okay? But keep in mind, this was a big group of people. So some people were actually much higher than 15 and some people were lower than 15, okay? The other thing that we can do for MDS to prevent transformation to AML is called an allogeneic stem cell transplant. And what that is basically it's a replacement of the patient's bone marrow with a donor's bone marrow. And the way I explain this to patients is that I do stem cell transplants for a number of different diseases, MDS and AML being one of those diseases, but I tell them that you have a broken bone marrow. We've explained why the bone marrow is broken before. You've got these cells that are mutated, they don't work, and because of that you have low blood counts, and we need to replace that broken bone marrow with a bone marrow that does break or that does work, okay? MDS is allogeneic stem cell transplant is actually a cure for MDS, and it's the only cure for MDS. It's the only way to get rid of it. But by doing that, you prevent the risk of transformation to AML. Okay, so it's very good in that sense. You get rid of all the problems with low blood counts, and you also reduce the risk of transformation to AML. Your MDS is gone if your stem cell transplant is successful. However, many of you may know this already, but allogeneic stem cell transplant is a very high risk procedure, and it carries with it about a 20 to 25% risk of death within the first year after transplant, and that's related to complications of the transplant alone, okay? So I take this very seriously as somebody who does stem cell transplants on patients, because I do not want to put patients through a very risky procedure if I feel that the risks far outweigh the potential benefits. So when I'm going back to thinking about risk versus benefit ratio, this is a very risky procedure. So I only would suggest this in highly selected patients who have one of two things: very high risk disease, so probably fall into the very high risk IPSSR score, and patients who I think are well enough and don't have medical problems that would lead to an increased risk of severe complications from the allogeneic stem cell transplant, which is this is a very difficult conversation to have with patients, because as I just said, it's a cure. Why wouldn't you want the treatment that cures your MDS? But it's not always a cure, and we can often make things a lot worse by doing a stem cell transplant, and in some cases can actually cause death for patients. So it's something that, although we do sort of hang the carrot of cure out with an allogeneic stem cell transplant, it is something that we can't do in every patient, because for a number of different reasons, because it may be deemed to be too high risk. Okay. The final objective that I'm going to talk about is to explore the treatment of AML transformed from MDS. And hopefully once I'm done this, it'll leave us about 20 minutes or so for a question and answer period. Anytime that we treat AML, whether it's transformed from MDS or not, there are two main things that I look at. First is the patient's age, and second is the overall fitness and medical comorbidities the patient has. And these two things really help me determine the patient's ability to tolerate the treatment that I would suggest for them. Again, I've been sort of harping on this over and over. I'm always trying to weigh risks and benefits. Many of the treatments that we can give for AML transformed from MDS are very aggressive treatments that, although they're good to they're the best ones to potentially cure the AML, they also have the most side effects and most toxicity associated with them, and also similar to stem cell transplant, albeit lower, do carry a risk of death associated with the treatment itself. So something that we have to take into consideration. So I use age and the patient's fitness. And when I talk about fitness, I talk about the patient's ability to how independent they are. Patients who are living at home, cutting their grass, shoveling the snow in the wintertime. Those are very fit patients, where some of the other patients I see are, for instance, in a personal care home, not able to do things like dress themselves, bathe themselves. Those patients I don't think are going to be as able to tolerate the treatments that I'm willing to prescribe. So based on these two factors, your physician will make an assessment of where you fall in this treatment pathway. And there's two options. There's high intensity induction chemotherapy, followed by an allogeneic stem cell transplant. And that's usually for the younger, fitter patient, okay? And then there's lower intensity treatment without a stem cell transplant, okay? If you can't tolerate the high intensity treatment for induction chemotherapy, it's unlikely you're gonna be able to tolerate an allogeneic stem cell transplant, because the risks or side effects of these treatments would likely cause you to be much worse off than if you didn't have the treatment altogether. So in those patients, we just suggest lower intensity treatment without a stem cell transplant. For the younger fit patient, the standard of care for AML transformed from MDS is a drug called Vyxeos. The trade name for this is CPX-351. And it's given as an IV infusion every other day for 3 doses in hospital. And generally speaking, when that's the case, patients stay in hospital for about 4 weeks. And after 4 weeks, a bone marrow biopsy would be repeated to see if the patient's AML is gone, i.e. whether you're in remission or not, okay? And if you're in remission, usually a couple more cycles of Vyxeos would be given while you're planning for an allogeneic stem cell transplant. And at that point, the allogeneic stem cell transplant would be performed, looking to cure both the AML and the MDS altogether, okay? There are some other drugs that might be used, or drug combinations that might be used in centers where Vyxeos isn't available. Vyxeos is a relatively new medication and is not approved in some provinces. So there might be a combination of chemotherapy called 7+3, which is actually almost identical to Vyxeos. It's just given in a different formulation. 7+3 would then be followed by an allogeneic stem cell transplant as well. Okay. For the older, less fit patient, the standard of care for AML transformed from MDS, the combination of Azacitidine, which is the drug I talked about before, and another drug called venetoclax. Azacitidine is given as a subcutaneous injection, like an insulin injection, every 7 days, 7 days in a row, every 28 days, okay? It's the exact same as what I was talking about for when we're just treating MDS per se to prevent progression of AML, or of MDS to AML. Venetoclax is a pill that's taken once daily for 14, there's a typo there that should be corrected. That's meant to be 14 to 28 days, and that's up to your physician every 28 days. Patients will stay on this regimen generally until it no longer works. In other words, your MDS and AML progresses, or it's no longer tolerated. This drug combination has some more side effects than azacitidine alone, and there may be periods of time where patients need to come off of the drug combination because they're having issues mainly with blood counts being too low while on the venetoclax. and azacitidine, okay? And again, because you would not be able to tolerate the intensive induction, most commonly for these patients, they just stay on this until it no longer works or it is no longer tolerated, and there's no allogeneic stem cell transplant planned for such patients. Anecdotally, again, this is a relatively new drug combination that we've had in Canada maybe for about 2 years now, and anecdotally, I've had quite a bit of success with this. I really like using it, and patients really like it as well. One thing I want to emphasize, and this is something that I think some people have a bit of difficulty accepting or wrapping their heads around, is best supportive care is always an option. It's always your prerogative to decline treatment and focus on quality of life. All of these treatments that I'm talking about can impair your quality of life, whether it be because of side effects or because of coming to the cancer center, getting injections. In some provinces, you may have to pay for some of these treatments. There's a number of different things that treatments can cause impairments on your quality of life, okay? It's always your prerogative to say, no, I don't want any treatment. And that doesn't mean that you aren't gonna get any care. Okay, I think that there's a difference between treatment and care. You'll always be able to get things that like transfusions, or there's some other medications that can help support your blood counts and make you feel better. And anecdotally, I've seen patients live for many months with AML that's transformed from MDS. And those patients accept that their life expectancy may not be as long as they would ideally like, but they go on to live very happy lives that are not interfered with by treatments. And I think that's something that is really, again, it's difficult for us to accept because we're talking about not doing everything we can to extend our life as long as possible. However, I think quality of the dogma in medicine is changing a little bit, and we do focus on quality of life now. And I think that's very important. And most importantly, I always want you to think what's best for you and your loved ones, because we as physicians, we suggest treatment based on medical studies that we read, and also on our experience in treating patients. But what our job is to give you the information that we have, and I want you to always think about what's best for you. And again, sometimes just saying, I don't want any active treatment against either my MDS or AML. I would rather focus on quality of life. That is a totally acceptable thing. If that's what you feel is best for you, I would highly encourage that, okay? So that's all I have to say with respect to the objectives that we've gone over. I hope that I was able to explain these objectives in a way that isn't too medicalized, and I hope that everybody understands and was able to gain something from this based on the questions that they may have had. At this point, I'm totally happy to spend the next 18 minutes or so answering any questions that might have come up.
Thank you so much, Dr. Brand, for sharing your expertise and insights with us today. Yeah, as you said, it is now time for the question and answer period. If you haven't done so already, please be sure to use the Q&A box on your Zoom panel to type in your questions. And we're going to try our best to get to as many as we can. If we don't get to your question, we will be following up afterwards. So look out for an email from one of the community services team member. So I know there was a couple questions submitted before and then during. So let's go to the first one. So you talked a little bit about treatment for MDS as well as AML, but is there any sort of new up and coming treatments that you're like excited about or that look promising in terms of treating either blood cancers?
There's always up and coming treatments that are being studied. I know here in Manitoba, we're opening a new clinical trial for MDS as well as AML. using azacitidine venetoclax in combination with a new monoclonal antibody. That's probably the most, the monoclonal antibody is called magrolimab. I have difficulty spitting that out sometimes. That's probably the most exciting thing right now that's sort of on the forefront. But we as hematologists and oncologists, we're always going to conferences and hearing about new and exciting treatments that are up and coming. I am not, I don't think there's anything that's imminently going to be approved in Canada that I'm aware of. But one thing I didn't mention, which I think is always important, particularly if you are highly treatment seeking, is to always ask your physician about any clinical trials that may be available for the disease that you have. Because the only way to know is to ask. So that would be what I would suggest is the best way to know about those things. But nothing imminently that's going to be approved that I'm aware of, but certainly some exciting things that are going to be in clinical trials. And then clinical trials are always coming up. So always ask about that.
Definitely. That's a great reminder to everyone. And then you can also reach out to the community services team. We have access to clinical trial coordinators, so we can also help assist with that process as well if you just wanted to kind of explore your options available. All right, so someone asked, I had a stem cell transplant back in 2015, doing great. I have an annual consult in August. Should I ask them to do an RIPPS to determine risk?
So I'm not exactly sure the details of this, but if you had a stem cell transplant in 2015 and you're doing well, at this point, assuming your transplant was done for either MDS or AML, you would theoretically no longer have MDS or AML, so there would be no need to calculate an RIPSS score because you actually don't have the disease anymore. And it's great to hear that whoever asked that question is doing great post-transplant. I always like to hear success stories.
Awesome, thanks. Someone asked, can MDS treated with a transplant come back as AML, or would it come back as MDS if there was to be a relapse following transplant?
That's a good question. It can come back as either, okay? I would say most commonly it comes back as MDS before it comes back as AML, but it can come back as as AML.
Right. So we had a couple people ask, can you get MDS from AML? So can like the reverse happen? Can you be diagnosed with AML and then it turns into MDS, or does it only work one way?
That's another really good question. So it usually doesn't work the other way. But what I will say is that, and we see this relatively frequent, I shouldn't say relatively frequent, but it can happen. Someone who has AML and gets treatment for AML with chemotherapy and or a stem cell transplant, the treatment itself can cause MDS in the future. And that's one thing we didn't talk specifically about what causes MDS. But one of the more common causes of MDS, or at least sort of identifiable causes of MDS, is previous treatment with chemotherapy. So if you've had AML and you were treated with chemotherapy, you are at risk of developing MDS secondary to that treatment in the future. That also goes for any other type of chemotherapy that people have received, whether it be for AML or for a solid tumor malignancy such as breast cancer. Which is a very common one that we see. So AML typically doesn't revert back into MDS, but treatment for AML can cause MDS usually 5 to 10 years after treatment. Sometimes a bit sooner, but usually in the 5 to 10 year time frame.
All right, perfect, thank you. Someone asked about the relationship between myeloproliferative disease and MDS. What if your bone marrow shows both? So is there a relationship, I guess, for MDS and like the MPNs?
Yes, absolutely. So normally when we talk about MDS, there's the myelodysplastic syndromes and then there's the proliferative neoplasms, and they're separate. When we have a book that's put out by the World Health Organization that classifies all of our diagnoses into categories. So there's those two categories, but there is a middle category that we're starting to recognize more, which we call MDS MPN crossover syndromes. And the most common one that you'll see, and maybe this person may be talking about that, is something called chronic monomyelocytic leukemia, or CMML, is probably the classic MDS MPN crossover syndrome. So the answer is yes, they can be related. And it's something that we're starting to recognize more. And in fact, they're actually, when you have those two syndromes together, they're actually often treated very similarly to MDS per se.
All right, thank you. Good to know. Someone asked, you mentioned the medications. Oh my goodness, I think I'm going to butcher this. Azacitidine and Venticlax.
Yeah.
How long do they typically? You said that they could be used as treatment for either as long as they're tolerated or as long as they're effective. How long does that usually last?
Yeah, so when it's used to treat acute myeloid leukemia, the combination of azacitidine and venetoclax works. It has a median overall survival of 14.1 months, so just over a year. Again, that's median, so some people were less, some people were more. I will say that in the context of what we're talking about today, AML transformed from MDS, that's usually AML transformed from MDS is usually seen as, or thought of as, a bit more of an aggressive form of AML. So if you did looking at the subgroup analyses in that trial that I quoted, the 14.1 months, the patients who were transformed from AML or from MDS were slightly lower. And truthfully, I don't remember exactly what the number was, but it is slightly lower. But on average, for all comers, it's 14.1 months.
All right, perfect, thank you. So someone in the chat asked, here at our center, we typically use 3 and 7 inductions as first line for AML. We have yet to use another one of those medications, Vyxeos. Do patients typically tolerate this regimen well in your experience?
Yeah, so one thing I'll just say, so this person mentioned 3 and 7 or 7 and 3, which is a combination of 2 drugs called daunorubicin and cytarabine. Vyxeos is actually a combination of this exact same 2 drugs. It's just in a different formulation, but it was studied specifically for secondary AML transformed from MDS. Patients do typically tolerate it well. The main issue with it is that it's actually much more toxic on the bone marrow, and the time for your blood counts to recover is generally about 7 to 10 days longer than with 7 and 3 on its own. So the median time to blood count recovery after infusion is about 35 days with Vyxeos, whereas with 7 and 3, it's closer to sort of 21 to 25 days, depending on which trials you look at. But otherwise, the tolerability is exactly the same and the exact same side effects as 7 and 3.
All right, perfect. I think we have time for maybe 1 or 2 last questions. So one came in. So if you have a low risk MDS and have been, sort of stable for a while, what is sort of the likelihood that it would transform into an AML? I know it's pretty specific, but I guess in your experience, do you find if it's so slow growing that it will kind of stay slow?
So this is going to be based on the answer to this question is based on my experience alone and not based really on any data. But I would say generally if patients don't transform, if it's been stable, I don't know what a while is for this particular patient, but for a few years, I generally see it as less likely that they'll transform. But that's based on experience alone. It's not based on any specific data. You'd have to look at trials specifically for low risk MDS, which there's not many trials on that because it's actually fairly poorly studied population because these patients don't get treated. So they don't have a lot of contact with healthcare. So it's hard to study these patients. But in my experience, patients, and again, as I said at the beginning of this, my dad was just diagnosed with a low risk MDS. So I kind of told him that, in all likelihood, you're not going to progress to AML. And if you do, it's probably going to be soon. And he's actually kind of had low blood counts for a few years now. So I kind of told him he's probably kind of out of the woods because the rate of progression of his MDS is quite low.
Right, perfect. And good to know for your dad.
Yes.
We're thinking of him. I'm glad that it's a slow progression. Someone asked, and maybe this will be our final question, does AML always progress from MDS? So even if you were diagnosed with AML, did you have MDS before and just not know it? Or can they be sort of mutually exclusive?
That's a great question. The answer is no. I simplified it, the description of how AML develops for the purposes of this talk, but no, you can have AML that is not from MDS. There's very specific criteria that we use to diagnose what we call secondary AML, which that's when it has transformed from either MDS, one of the myeloproliferative neoplasms, or one of the crossover syndromes. There's very specific criteria we use to define that, but you can have AML just on its own. It does not have to come from MDS.
All right, perfect. And actually, I saw that we had more questions pop in, so maybe we'll just take 2 more minutes.
Sure.
Let's see here. Someone asked, okay, intermediate IPSS, normal hemoglobin and platelets, low neutrophil counts. Does that change the calculation in the tables regarding progression to AML?
Sorry, can you explain that again?
Yeah, so they asked about having doing an intermediate IPSS or the results are intermediate. So a normal hemoglobin and platelets, a low neutrophil count. Does that change?
And I'm assuming and I'm assuming for this person, the cytogenetics or what has caused them to be intermediate risk.
It doesn't specify.
Okay, it doesn't specify. Okay. I'll assume that, so I think what this person is asking is, even though they have relatively normal blood counts, but they're still intermediate risk, does that change the progression? The answer is, based on the IPSS study, the answer is no. It sounds like that person, the thing that's driving their intermediate risk is the cytogenetic abnormality. And the cytogenetic abnormality, even though it's not leading to low blood counts, we know from studies that those cytogenetic abnormalities put you at higher risk of transforming to AML.
Okay, perfect, thank you. And so for the last one, is there sort of a typical treatment plan if a patient relapses after an allogeneic stem cell transplant following an AML diagnosis? Following
an AML diagnosis. So yeah, so the typical treatment plan, first of all, it depends on how old the patient is now after their stem cell transplant, what type of medical comorbidities they have, their overall fitness, all the things that I talked about. The first, but let's say the patient is, ready to, is still young and fit. We would try to induce another remission of the AML. And then in my center, we would likely try to proceed with a second allogeneic stem cell transplant if we can achieve that remission. However, if the patient is either not fit, has a bunch of medical comorbidities, is too old to receive a stem cell transplant, or says, I already did that stem cell transplant thing once, I don't want to go through it again. We would generally, in my center, what we would do for that patient if they relapse would start them on azacitidine and venetoclax if they've relapsed after an allogeneic stem cell transplant.
And is that sort of the same protocol if it was MDS to AML and then transplant?
Yep, absolutely.
Perfect. Well, thank you all so much for getting in your questions. I know we got quite a bit at the very end. So a community services team member will try to reach out to people via email to, help answer any questions that weren't answered during this webcast. So if you can go to the next slide, please. Perfect. So again, thank you so much to Dr. Brown for being with us here today. I would like to remind everyone that we are here for you. Do not hesitate to contact either the Leukemia and Lymphoma Society of Canada or AMAC if you need more information or support concerning this topic, or to get more information on any of our services. All our contact information is available on the slide. Also, be sure to check out our website, bloodcancers.ca, to learn more about upcoming webcasts, podcasts, and special events. Please note that a short survey will be sent to all participants following this webcast. We greatly appreciate you taking the time to fill it out, and it really helps us gain feedback and information as we look to the future to create more of these events. So thank you all so much for being with us here today, and I hope you all have a wonderful rest of your day.